do you deal with overwhelming stress and headwinds that come from different directions? So we have a lot of questions for her, but Dave, over to you.
Yeah, thanks, and so excited to be here today to talk about Revitalized and Dr. Austin's work. And again, thank you to all the veterans, including Dr. Austin, for your service and all the sacrifices you've made. It's great to be here with a group of vets on Veterans Day. So excited to do this. Um, so my background, I'm a Navy pilot. Was my first career, and then second one in academia, and started at the Naval Academy and teaching there. That's where Brad and I began our collaboration and doing our work. And now I teach at Johns Hopkins, and so now I get to work with not as many vets, but a whole lot more folks in the healthcare industry, of course. And so spend a lot more time in that world, and so excited to get started here today. So, Brad, do you want to kick off with the first question, or would you like me
Y-
to?
Yeah, no, I'll kick off here. I think maybe first question, Dr. Austin, based on Dave and I getting to look through your book with great interest. It's so interesting for me. The subtitle of the book is Heartline, and this is all about kind of returning to the Heartline. And I just wonder if you can begin by giving us a little context, right? Operationally defining kind of quickly, maybe what does that mean? Because I think it's such a helpful term that I haven't heard before.
Yeah, and admittedly, I hadn't heard of it until a few years ago, and the metaphor just really resonated with me. So if everyone looks at their palm and finds the longest horizontal line on your palm, that's what readers call your heart line. I'm certainly not a palm reader, and I practice evidence-based medicine, but this heart line is said to represent your emotional well-being. And when I really sat with that, I think part of what's happening in healthcare right now is a lot of us have been asked to turn away from our heartline, to be cold and objective and focused on metrics all the time, instead of really thinking about how can we connect with our patients and how can we connect with ourselves.
Yeah, it's really helpful. Yeah, I
Yeah,
love it. We're going to have to use that more, Dave, in
I
our
know,
work.
I know. Well, now that we've established that you're not a
Yeah,
palm reader,
yeah, right.
maybe we can talk about your chosen profession and what attracted you to your profession. And are there things today, right, new factors along the way that have really renewed that commitment, that passion and drive that you have for the profession?
Yeah, and when I think back to what drew me to medicine, it was actually job shadowing a physician associate in my hometown of Vinton, Iowa. And following her, and again, listening to patients' stories, I found fascinating. And this blend of science and getting to interact and talk with people really drew me in. As far as what's keeping me in healthcare, I still obviously care so much about our patients. The other thing I care a lot about, though, is our healthcare professionals. And so a lot of times when I'm going into my shift, I taking care of the patients is a given. What I'm really focused on now is taking care of the people around me.
Mm, yeah.
So, Andrew, I don't know that we talked about this before. So my family is from Iowa,
Oh,
and
wow.
my grandfather served on the city council in Benton. Um, we grew up in a farm in Shellsburg, Iowa. And we used to call it going. They call it going into the city, going into Benton, because of course Shellsburg was really just kind of a crossroads and a couple of farms out there then. It's a small world.
That's crazy. I know exactly where Shellsburg is because we did this weird thing in sixth grade where all the kids from Vinton got bused to Shellsburg for sixth grade only.
Mm,
Oh wow,
yeah, yeah.
who knew?
Who knew?
So I have a question that really kind of emerges both from reading your book, Dr. Austin, but also our conversation earlier, just about your experience of often being as a woman in emergency medicine, and especially in the military, and only in the room. And I think you're not alone in terms of women having that only feeling, which tends to be exacerbated, of course, for women of color, often feeling like they're the only. How have you experienced that yourself? Just curious. And also, how have you learned to adapt and cope with that? What are some recommendations you might have?
Yeah, and I'm so curious what some of the other women think about this, and maybe they can type into the chat. When I was a medical student and people would be, surprised that I was the doctor and not a nurse on the team or a student doctor, it never really bothered me. It just kind of like I don't know, like brushed over me. And part of it, I think, was I was surprised I was there. So I wasn't that surprised that somebody else was surprised I was there.
Mm.
But then as I progressed and I started to get more feedback that not only did I belong, that I was a really good doctor. When I started to hear all the time, like, you don't look like a doctor, or, those type of comments, it really upset me, like
Mm.
on a visceral level. And I think the more I got exposed to all the information about bias in the workplace, then it made me even more mad. And it's not exactly easy to be taking care of patients and working in the emergency department and seething with um, anger over, discrimination. I did that. I wouldn't recommend it. So what really helped me kind of move past all of that was honestly being part of AAWEP. And what I started to learn is I could get really irritated with comments like that and burn through a lot of my emotional energy on a shift, or I could save that to fuel the work I do with AWEP and other organizations to have more equity. I feel like I lost the thread a little bit. I
Yeah.
think I got caught up in that emotion, thinking back
Yeah.
to all those years where it was just so frustrating. But I know where I was going to go with this. What I finally decided is I'm never going to look or sound or be like a lot of people's idea of a doctor, or maybe even one that they resonate with or like. Um, and I'm not responsible for changing
Mhm.
their ideas around this. And so, really, what I did is I just started leaning into my authenticity. This is who I am.
Yeah.
And I even changed the lab coats that I wear. I figure if the establishment doesn't really think I belong, then I'm not wearing the white coat anymore. So Lori Bogie, which some people on this call know, is the founder of Green Cloud Scrubs. She's an emergency physician and Army vet, and she makes lab coats in all colors.
Hmm.
So now I wear those, and it's partially to support Lori, but partially because I'm kind of giving the middle finger to the establishment.
Yeah, yeah, yeah. Cathartic. It sounds cathartic to do that. So,
Feels
so
good.
yes, seeking community, I'm hearing,
Yeah.
right? With other women in the organization, maybe some male allies too along the way. Not owning other people's reactions,
Mhm.
and leaning into your authenticity. I like all of those. Dave?
Yeah. So I think, one of the things that resonated with me was this, and Brad and I talk about this quite a bit, and we probably talked with you quite a bit about it as well. And a lot of the groups of people, the networks that we're involved in, who's in and who's out. Brad and I, are really focused on trying to help men to diversify their own networks. But in many ways, it can be very kind of exclusionary in a lot of these different networks. And you talk about, I think, just like me networks is the way you rephrased it. Um, but I think this is an important point for all of us, right? No matter who you are out there, and about how do we think about diversifying our own networks, right? And being very purposeful about who's in our networks and what that brings to ourselves as well as others, and how it contributes to the broader inclusion around the workplace. And I think that's what we're trying to get to, is that inclusive culture in the workplace. And part of that is kind of all right, well, who do we flock to, and who do we hang out with and spend time with, and who do we share important professional knowledge and information with out there?
Yeah, 100%. And it's certainly something I reflect on a lot. And this call today is a collaboration with GSACEP and the women's section of ACEP. I'm spending a lot of time reflecting right now about the history of women's organizations.
Mm.
A lot of women's organizations, we have work to do on making sure we truly are an inclusive place. Historically, there's been some that have honestly catered more to white women. So that's something that I'm reflecting on a lot right now, in this moment, that we need to be a place that all women, and that we're making sure that we understand that underrepresented women's have a much harder time in medicine. And we need to make sure AAWEP and other women's organizations are really working on those issues directly.
Very
So
important.
one of the chapters in your book that I found really interesting, a little bit heartbreaking, is the chapter on hyper functioning in chaos. And I feel like a lot of folks on the call, including myself, can maybe resonate, but it feels like one of the headwinds that women might be more likely to encounter. So I'm wondering if you can tell us about the epiphanies you had along the way when it comes to your own hyper functioning, over functioning. Why does that tend to be such a headwind for women? I know there are a lot of ingredients. And how have you responded to that kind of on your revitalized journey?
Yeah, well, I just recorded a podcast with Jessie Gold today, and she has a wonderful book out this year as well. And she's a psychiatrist. And we were talking about this, she's feeling this hyper functioning too. And what her response was, we just need to be more curious, like what's underneath of it. And what's underneath of it for me is a little bit different than what's underneath of it for somebody else. A couple of things, physicians, we love differentials. Differential for hyperfunctioning, for me, one was childhood. Something I talk about in the book is I encourage everyone to take the Adverse Childhood Events, ACEs inventory. And, whether you score low, medium, or high, there might be something that you need to attend to there. And that some of that, for me, hyperfunctioning really started in childhood, that I couldn't always count on my mom to even know when to take me places and pick me up. I tell a story in a book where I got left at a church, and it sounds like not a big deal, but it was dark and it was really scary as a 5-year-old child, and having to figure out how to get home that night. So for me, it started there. And then I think medical school really kicked it into high gear. And when you look at resident schedules, 80 hours a week, I can't even believe when I say that out loud, it sounds so crazy. How do you get through anything at 80 hours a week without hyper functioning? So I think some of us come into med school already with those tendencies. And then I think medical school and residencies really at this point still demand hyper functioning.
Yeah. Yeah. So, quick follow on with that, Andrea. For those of us who are teachers, mentors, in any kind of supervisory role for people in a training track, how do we help with that? Just knowing that's a tendency, maybe for medical students, for residents, for trainees. How do we notice it and help mitigate that?
Yeah, I think if you're in a leadership role, you need to look at what you're asking people to do. And this has certainly been something I've had to reflect quite a bit on. If my base tendency is to hyperfunction, what am I asking the people around me to do? And for years, it was to hyperfunction. I now that I know that's the way I tend to operate, I have to talk with my teams and say, you need to rein me in when I get overly excited about things or deadlines in particular. And creating, that's the thing, psychological safety isn't, something that you snap your fingers and create. It's something that continues every day. Every word you say and every word you don't say contributes to psychological safety in your culture. So I think normalizing these conversations, and people deserve privacy, but I'm very thankful for like the simulation team that I run. We have a very open relationship with everyone that works in the lab, and knowing what's going on with their families, and that people may need time off, or whatever they're navigating. So I think people right now, a lot of the colleagues I work with in emergency medicine don't always feel like they have that, especially for women around child issues, whether it's child care, whether it's being pregnant, whether it's dealing with a pregnancy loss. There's still a lot of doctors out there that don't have that in their work environments, which is just sad and incredibly ironic, since we're doctors.
Yeah. Thank you.
Yeah, the, the whole discussion around the hyper functioning also, it also reminds me of, so I was a military brat, and I grew up in that world, and I think I always felt like we were being pushed, I don't know, or expected to live, and to exist in that kind of functioning every day in many cases, and those who couldn't, they were somehow lesser than or something. Today, it seems like we talk about this a little bit differently, in terms of the value and of what it creates in us. And this is the term, resilience, that we often use.
Mm.
And it's used in so many different ways, and weaponized, I think, also in different ways too, that is unfortunate. But I'd love to hear from you, so what does it mean? What does the term resilience mean to you, especially in a healthcare setting? And then how do you see it used? What are the challenges with the way that we're defining it, or the people are using it?
Yeah, I think resiliency is almost a triggering word for healthcare professionals at this point. I mean, you look at, the incredible resilience that everyone shows every day, and then obviously the pandemic. Just recently, and I'm still thinking about this more. I'm beginning to think that, and I'd love to hear your thoughts on this, using agency as a bridge to resiliency. Because I think a lot of times resiliency, especially in the healthcare context, is about grit. And we've got that in spades. But what I really like about this idea is, of agency as a bridge to our resiliency, is you choose what you need to be resilient. And sometimes that is digging deep and pushing through, but frequently for healthcare professionals, that's taking a break, or it's walking down the hall and spending a few minutes chatting with a colleague, and using those moments to have that community on shift, bond a little bit, get that support, that tend and befriend response that regulates our nervous system. So what do you two think about the idea of agency being a bridge towards resiliency?
It resonates with me, and I agree with you. I think the grit kind of terminology and concept is often how some people think about resilience. But I often also think that it's important to remember that resiliency, again, why the value, to me at least, my perspective on it is, from an evidence-based side of it, is really that when you experience something that creates a stress, right, that helps you to, maybe it's a new situation, a new context, but it helps you to grow, maybe to develop new skills, to strengthen something that you already have, so that in some other opportunity down the road, you're now kind of equipped to do something else, right? Not necessarily always to dig deeper to do more, right? Which is kind of that, to me, that's the grit perspective of resilience, but really to be able to kind of expand my portfolio in the way that I can lead in a different situation, that I can manage in a different situation, or interact with people in a much more productive way in a different situation, a context out there. So it's adding to I think about it, how it adds to my portfolio to be more capable in that way. In the same way that, you can think about that's from an individual perspective, and we can talk about it from an organizational perspective too, about how we can build organizational resilience in terms of growing capacity, and not always about how do we handle things in the moment of crisis. It doesn't always have to be about a crisis in that way, but curious what Brad's thoughts too.
Yeah, no, I love that. And, I think in our earlier conversation, Andrea, we mentioned Dr. Heidi Kraft and her work as a deployed psychologist in combat. Um, and she uses the term, and I know other people have used this, but it resonates with me. She does a lot of work with PTSD, post-traumatic stress, but she's big on the idea of post-traumatic growth. And I think there's a lot there in terms of what I'm hearing from you about agency. PTSD, as just one example, doesn't need to be kind of a one-way street to pathology and disturbance. There might be something in it for you that actually makes you stronger on the other end, but it's how you approach that, what you do with it. You mentioned doing some self-care, walking down the hall, getting some community. I think people can do that after all kinds of experiences. And so I think it's a really hopeful message. I love your agency take.
Thank you.
Hey, so I guess on this note, I hate to go dark here, but let's talk about trauma and let's talk about really difficult experiences. I know you've been there yourself. Um, I think I want to frame the question this way: when is it okay among emergency medicine people not to be okay? Or is it ever okay not to be okay? That might be a more important question. Do you have permission to be human, to fail at times, to be, so affected by something that you're just not competent for now? Can emergency room docs share that with each other, or is that dangerous or threatening?
Yeah, I would say I still think it's pretty risky. What's giving me the most hope right now, and I would encourage everyone to go to this website, is the Dr. Lorna Breen Foundation. And I know many people on this call are familiar with Lorna's story. She was an emergency physician working in New York. She was a medical director. And at the very beginning of the pandemic, of course, New York was hit so astronomically hard. She contracted COVID and she went into a depression. She was convinced that she would lose her medical license. And this was despite, in retrospect, which is so painful, that New York State actually does not ask if people have a mental health diagnosis. So one of the good things that's happening is her foundation. Unfortunately, she committed suicide, but her brother founded this beautiful foundation. And one of the most important things that they're doing is working with state medical boards to take that question out. We should not be asking people if they have a mental health diagnosis or any diagnosis. The question that needs to be asked is, do you have a condition that's preventing you from working, as a capable, affecting the way you provide patient care? And what we know about mental health and health in general is we can have all sorts of diagnoses. The question is, are you getting them treated? And so what I really hope is that we get to a point in healthcare where the question's not, have you gone to a therapy? I mean, have you gone to a therapist? The answer is resoundingly yes. I think most of us have something in our past. And if you had the most perfect childhood of all time, congratulations. But working in healthcare will probably make you need a therapist.
Yeah.
And especially under these current conditions that are so dysfunctional. So to ask doctors, have you been to a therapist? That is still taboo, and that we are essentially still receiving so much flack for that. Unfortunately, the answer is people aren't safe right now. But what I hope is people feel safe with each other, and that spaces like AAWEP, GSACEP, wherever that is, that you can find that space to be safe with each other, and that we'll continue to do the work to make the system safe for us. But we have to create those spaces.
Yeah. Yeah. Dave, can I ask one follow-up question here? Just so I'm really wrapped up in this conversation with Dr. Austin. So this just feels so important. So let me just take it a step further with the "is it okay not to be okay?" There is a philosophy from Africa, Ubuntu philosophy, that basically says we are only people through other people, and I've seen that extended to healthcare providers. It really, maybe in your profession, you're only a competent emergency medicine physician through other competent and caring emergency medicine physicians. So my question for you is, how do you show up as a caring communitarian ER doc and notice when a colleague is not doing well? And is there a way into that conversation? So I convey to them it's okay, first of all, but also let them know that they're not alone and there's a way forward. How do you have words for us, or have you found a certain approach effective?
Well, I think it starts way before that day that you need to have that conversation with somebody, because most of us, our barriers are really, really, really high. So if you haven't contributed to the trust bank account that I like to call, a lot of us aren't going to be able to divulge anything. So the other day, I got a text message from a resident saying that she didn't think she was going to be able to make her shift with me. And she shared what was going on. And so we strategized how she could move forward in a way that would protect her and also be ethical, walk that line that there were certain things she needed to communicate with her program. And I reflected on, how much it mattered to me that she was able to share the behind the scenes and that we were able to come up with a way forward together. So again, I think, we have to really be trying to be as good as we can to each other, understanding that the system treats a lot of us really badly. And it's easy to transfer that energy to other people. I think about that a lot as an ER doc. I'm always calling people to do more work, So when I call that consultant and they kind of lose it on the phone, it's very easy for me to serve it back. And over the last few years, I've done a much better job of pausing and, asking if they're okay. And, kind of meeting, instead of fire with fire, fire with compassion. And it's been striking, the responses that people have had. Quick a side story, but I think for this group, it's helpful. I had a colleague, a male colleague, question my clinical decision making in front of many people, essentially accused me of not managing a case correctly and kind of spouting off what the ACLS treatment was. And I was just really floored by it. Like, I had never had anyone do that to me in front of a group of people. I mean, this was like a year ago. I've been out of residency for nearly a decade. And an earlier version of me would have just not said anything. And maybe a little later version would have fired back something really bad. And so I just sat with it for like 20 minutes. And then I made a decision that I wasn't going to get in the car that night without having a conversation with him. So I asked to speak to him outside, and I just was super vulnerable. And I just said, what happened hurt me so much. And I just explained that it wasn't just what happened there. It was the 15 years of crap before that. And he actually cried. And we ended up having like this really like vulnerable exchange. And to this day, he has my back. And he's learned that, to ask. There was a day I was kind of struggling with a shoulder dislocation, and he came up very politely and collegially and asked if he could, offer a suggestion. And it's been great since then, which makes me think of something I've introduced in the book, this idea of the rupture. You can have a rupture with somebody, an argument, and it can either go terribly bad, or it could be an opportunity to move the relationship forward.
Yeah. Yeah.
I love
Powerful.
that.
Yeah.
Yeah. Because, we talk about this in so many different ways about that vulnerability or openness or transparency or authenticity. It gets talked about in different contexts, but it really does it can build connection with people if it's done right. And I love that. I know we're gonna run out of time here, but I wanted to ask, I was dying to ask one more question, at least one more here. If we talk about, I remember back in my days teaching at the Naval Academy with Brad and a lot of our ethics classes and leadership classes about in terms of combat around moral injury. And and we talk about it a lot, of course in the service, around the idea of combat and how that affects people and what that looks like today, and how technology can affect that, and so many different factors that can affect it. But I was wondering if you had any examples or anything you could share around moral injury in your profession, in your experience.
Yeah, I mean, it's not lost on anybody on this call that we're dealing with astronomically high levels of moral injury. And it's really important that we define what it is. I think this is really the number one thing underpinning emergency physician burnout. Because when we go into our shifts right now and our EDs are so dysfunctional, we can't help but be hurt by that. I think about days where the boarding is so bad that I can barely walk down the hallway. I'm like having to like shimmy in between in beds. And I've got, a patient with a psychiatric emergency that's literally been on a hospital bed in a hallway with the lights on for 72 hours straight. Some of us that have served in the military are aware that leaving the lights on is a torture tactic. I honestly think we're going to look back on the way that we've been treating our psychiatric patients in the emergency department, and there will be books written about the damage that we've done. And I feel complicit in that. And I've really had to think a lot about is still going in and working in an emergency department, knowing that things like that are happening, how much of that is my responsibility? And again, what I've come down to is I think it's still better to go in and work sometimes clinically. I work a lot less clinically than I used to. As long as I'm working to make change outside of my shifts. I do the best that I can with what I have. And I try to be an ardent advocate on shift. And then I have to keep working on things out of shift because I feel it's a moral imperative. So
Yeah.
I think the moral injury is incredibly real. One of the things that I hope will happen is there's actually something called a moral injury severity scale that's been developed and trying to be validated in the healthcare context. I think we have to hold our healthcare organizations accountable. And perhaps if we have a scale like that and we see high levels and it's variable depending on the emergency department, we can start to push back that no, this is an unacceptable level of distress that you are causing the people working here.
Yep.
I love the accountability piece, right? It's so much of, creating change takes one getting evidence or data in front of people. And a lot of times that's what creates the holding them accountable for it.
Yeah, and that's been missing in emergency medicine. And some people I know on the call are familiar that AACEP is working to accredit emergency departments. This kind of blows all of our minds. There's never been a comprehensive accreditation for an emergency department. Like there's many different types of accreditation for trauma, for stroke, for heart attacks, but never one big set of this is what you actually need to be an emergency department. And without that, we really don't have that accountability piece. So we need to start clearly stating that we need, social workers. We need the appropriate specialists to be on call. We need CT results to be turned around in a certain amount of time. I mean, there's shifts I work right now and I don't get a CT read for more than 6 hours. And then where does that put me? Well, what patient safety, and then also just having to communicate with patients about, I'm the face of the failing healthcare system and their understandable ire against it. And, they'll say to me, but you're the doctor. Why can't you, I've been waiting 24 hours for my hospital bed. Why can't you make it happen? And it's not very satisfying to say that I don't have any power in this situation either.
Yeah. Sounds like a lot of emergency room folks need to read Revitalized, Dave. That's my takeaway here.
And administrators. That's
and
really
administrators. Yeah. Well, I wonder, we have about 13 minutes. I wonder if this would be a good time to open it up to our esteemed audience and just kind of make it some really great, robust, I hope, Q&A about some of the conversation you're hearing. You may have questions for Dr. Austin, and could be about her life and practice or her book Revitalized. But maybe we'll just throw it out. You can either raise your hand or just unmute yourself, whatever you'd like to do.
This is Lisa. I just had a question
Lisa.
about how, if you kind of recognize that you are like a hyperfunctioner, are there initial steps that you would recommend to take to potentially help to improve that situation?
Yeah, it's such a good question, Lisa. I think the first thing I would do is just start journaling about it. Have a journal with you, or even your phone. If you're not going to take a book, you can record a voice memo or type a quick note. What's going through your head when you feel that urge to hyperfunction? I think a question that's very helpful is, what story are you telling yourself related to that hyperfunctioning? And sometimes we find out that those stories are from things from childhood. They're from, sometimes we're projecting what other people might be thinking about us. And for the most part, what I found is other people aren't really thinking about us nearly as much as we think that they're thinking about us. And then two, the times that people are thinking about me, there's a very, very small group of people that I actually like truly care what they think about what I'm doing and my productivity. So that's where I'd start.
Yeah, yeah, some reframing there. Um, we have a question from Jessica Vaughn. It gets back to our earlier conversation about community. So, how do you define community? Is it geographic? Is it shared ideology? Is it shared action? Is it emotional support? So, how do you define it? And then also, how do you create that? How do you find it for yourself?
Yeah, I mean, in some ways, I feel like community is a overused word. But I think again, kind of going back to, what matters to you and what type of community do you need? When I think about going into my emergency department shift, there's certain people in my group that I feel that I have community with, that I can really keep it real with, that I can strategize with. There's a term in the social justice vocabulary of accomplice, and I never really understood what that term meant. It sounded so negative, but you truly need accomplices. You can't always be the squeaky wheel in your group. So there's kind of a group of us that take turns being that squeaky wheel, and that we've kind of learned, and this sounds calculating and terrible, but you kind of have to learn the political side and who has favor in certain situations. And that's one of the ways that, I have my community of ED docs in the place that I work. And then I have my AAWEP community. I have my simulation folks. I have my military people, all my military veterans. There's, text strings of military women vets, that I was messaging earlier today. So there's a lot of different ways to define community. I think it's where you feel good. It's where you feel that you can be authentic. I don't personally use the term community with any space that I don't feel like I can show up and really, really be who I am, and that I can lean on other people, and that I can be that hopefully place that people can lean on me too.
To take this community conversation even a little deeper for you personally, Dr. Austin, Dave and I often use the term inner core to describe a group of colleagues that maybe we have curated, right? Through, you mentioned trust, right? Here's a group of people who know me, who know that I'm counting on them to kind of have my back, to give me feedback if I step in it or my competence is ebbing. These would be the first people to circle the wagons and provide care, but sometimes the tough love I need to really receive some feedback. Do you have an inner core? And if you do, how have you kind of developed that over time?
Yeah, I love that question. And Tracy Sanson gave a great talk at our last AWEP meeting about talking about your front row. The people that are right there down in front. Um, gosh, I think a lot of your front row, honestly, is forged in tough times. When I think about who's in my front row, there's a lot of people that, saw the ugly full face cries, before I left for deployment, during the pandemic, those really, really hard times. So again, I think it's the people you can be honest with. And I think the point that you made, that it's the people that can challenge you. Um, there's a lot of superficiality in our society right now. And one of the things we know about women in particular that men will sometimes say is they don't think they can give women feedback that will cry. You know, my whole thing is I may still cry, but please still give it to me. And so I think having those people that care enough to say something, and bring, you know, be more than just a mirror, you know, be that person that can bring that feedback to you, and be able to deal with maybe the discomfort. So that's, you know, one of the ways that I kind of look for people that can, you know, be in that front row.
Yeah. Dave makes me think of one of our interviewees. My eyes may be moist, but my brain's working just fine.
Just
Thank
fine.
you.
Yeah.
Yeah.
Well, if I could turn the tables, I know we're wrapping up, but something,
Yeah.
and Jessica, if you can let us know the 3 people that won signed copies of the book, we'll announce that maybe in the chat. But I just couldn't help myself to not ask you guys this question. It's on my mind. And I don't mean to be a bit political. I think we can just keep it on the gender side. A lot of us, I think, are feeling like women are never going to pierce the tallest and the hardest glass ceiling. And a lot of us, I mean, just to be real with you, I cried the hardest I've cried in a really long time last week. And it wasn't, you know, about Republican, Democrat. It was about somebody that has been a sexual predator and pariah on women. So I'm having a hard time right now, just thinking about what does this mean for women. I know you guys have thought a lot about these topics. You understand men, maybe more than me. So what's going on right now, and what hope do you have for us?
Yeah. Well, thank you for asking the question. I think that you were in good company Wednesday, of course. So if that's helpful, you're not alone in feeling a bit of angst about that. You know, I guess my thought, I struggled a little bit on the day after, and then immediately began thinking about, okay, well, where do we go from here? Especially in the work that Dave and I do, trying to pull more men in to better equity and better allyship. And, you know, I think now we have an opportunity. I'm going to frame it that way, an opportunity to really work and be vigilant in the next 4 years, to mitigate stuff that's just not okay. Dave and I write about public allyship and good guys, and this is hard for men, right? Putting skin in the game. I need to say something when things aren't okay. Well, I think we've got now 4 years to do that in a much more public way when if our commander in chief continues some previous behavior and others who work for him, we're getting misogynistic messaging or examples or behavior. It's an opportunity to call that out. And frankly, people who look like Dave and I think have more of an obligation to do that, because plenty of research showing that when women or other minoritized folks do that, they pay a penalty. Um, Dave and I far less likely to pay any penalty. So we need to be on duty, I think, for the next 4 years. But Dave, thoughts you have?
Yeah, I think one of my takeaways last week was that this goes to me, this just proves the point about how insidious gender bias and sexism is, especially in this country, and how, because of the way you know, we've been able to come at it and really kind of, I think in many ways, kind of beat back a lot of the part that we see and is very obvious. So we've kind of pushed it underground in many ways, but there are ways that people can still that bias can still exist, and it shows up in very, you know, highly meaningful ways, like, you know, elections, for example, where accountability right? Accountability in the election for individual votes and things like that. It's a lot harder. It's a lot harder to get to, and understanding that we have a lot of work still to do. And as Brad said, I think that for me, it just kind of renewed my commitment to the work that we're doing is important. It's not anywhere close to being done. And that we need to keep working at bringing in more allies and really understand what it is that's driving this behavior. And also to kind of expand and thinking about the different populations. I think there was a lot of conversation about, why the messaging to, young white men, for example, or to Hispanic men, different groups and populations about why they this may still exist out there. And there's, again, it just shows me that there's more work to be done. And then we have to, again, renew all of our commitment to doing this.
And I want to call out, because Jessica's provided the winning
We have
names.
3 winners.
Yeah, Juana, Justine, and our old colleague. I don't mean you're old, Risa, but our good colleague, Risa Lewis. Good to see you virtually.
Yeah. I have to go be a camera off, but it's wonderful to be in conversation and to be a part of this. Thank you for having this today.
Yeah.
Special shout out to Risa. She's really the woman behind the scenes, because I've been admirers of Brad and Dave for years. But Risa has co-authored some work with them and was gracious in the introduction. So thank you so much, Risa.
Yeah.
Definitely.
Well, Dr. Austin, you get the last word. I think it's your show.
Oh, well, I just gratitude to everybody that took time to spend part of their holiday with us. I don't have anywhere to go right away, so I don't know if Jessica can keep the link open, but I'm happy to stay for a few minutes and say hi to anyone else. And so much gratitude to both of you for everything that you've done and continue to do. And it sounds to me like we need to just I don't know, get a lot of copies of Good Guys disseminated wider and further. This is definitely a book that I would encourage everyone on the call to give to their medical directors, their program directors. And it certainly after that, I felt like I could breathe a little bit more because I didn't have to be educating my supervisors anymore. You two did it much more succinctly and eloquently. And Good Guys. So I thank you for that.
I'll give them a copy of Revitalized first.
Yes.
Christmas or holiday bundles. We've got
There you
holiday
go.
Yes, we
bundles.
love lots of books.
Lots of books. All right.
Yeah.
Well, thank you, everyone. And continue to revitalize your career, many evolutions of our careers.
All right. Take care, everyone.
Take care, everybody.
Bye.
Thanks, everyone.